Dr. Jyoti Prakash will be covering on costly misses in pediatrics. The background slides aren't there, so I'm just waiting some power. We will wait for the power to come up. So in the meantime, I will just utilize this thing to brief up or summarize what is different in a child and when it comes to an adult. So in children, especially when we go for neonates, the most important thing is the transition phase from the mother's womb. The baby is in the mother's womb, and in the mother, we all know the children are having what
they are under fetal circulation, and after the baby is born, the baby starts to adopt to the newer place. So there is something called from fetal circulation to the normal circulation. That is a period where your ductus closes, the ductus venosus closes, and your lung, the baby's lungs, starts to function. So this transitional phase is a very critical phase in a child. So if we managing these children in this transitional phase is very critical. And as you know, the incidence of congenital heart disease is about 1 in 100 live births. It is not very less. So if you look at the statistics, the number of children born with congenital heart disease is if you look at the total birth rate in Andhra Pradesh, would be around 10,000 children are born with congenital heart disease every year. So we can miss a lot of things in these children if we are not very attentive. So what are those costly misses in neonates which can cost lives? Let's look at the reality. Okay. We think the child has cried normally at birth, everything is fine, mother is happy, child is happy, and discharged. But sometimes, after 72 hours, they come back to the clinic without any pulses. Why? Why is this? As I was just talking to you, that neonates are different. There is this duct-dependent circulation, okay, some lesions, which are very hemodynamically critical, and if the ductus closes, these can rapidly evolve. There is rapid physiological deterioration in these children. Sometimes there are very complex or critical congenital heart diseases with a silent chest. Okay, it doesn't mean that a child with heart disease must have a murmur, right? And most children can be deceptively stable, although they could be in compensated shock. I will quickly run through few cases. It is a 48-hour first case, a day 3 neonate who presented with 4 feeding, cold extremities, and severe metabolic acidosis. On initial assessment by the pediatrician or the treating doctor, he felt there was no obvious murmur, so he thought, okay, it's not a congenital heart disease, no sepsis, and no echocardiogram was done. However, what was missed was They did not check all the four limb pulses. There was no check of the saturation, and the echocardiography was delayed. Actually, it was a significant critical coarctation which was missed. So these are the critical systemic duct dependent lesions which we can miss, and if we don't diagnose, we can lose the children. Second case is a firstborn child. He was discharged after 1 week because it was an LSCS delivery. At third week, presented with poor feeding and mild tachypnea. Minimal children will not have what the adults have, significant rapid breathing. They might not be having this thing, but it will be very subtle. Okay, but if you check their saturation is only 60% on room air, did not improve much. Again, you see there is no murmur. If you look at the X-ray, this is the type of X-ray. So it all turned out to be an intracardiac TAPVC. Okay. So they can present late, these children. These are all life-threatening lesions. If you don't operate, they are not going to get better. Luckily, the child had access to pediatric cardiac care. He was operated and the child was discharged and he was doing well. Oh. No, slides are not moving. Something is wrong. అక్కడ స్టక్ అయిందా నో స్లైడ్స్ అక్కడ డిలే So as I described in these first two cases, one was a duct-dependent circulation lesion. The other one was a infracardiac TAPVC in a child who was diagnosed, who was thought everything was normal, but went home and diagnosed in the third week. The most important thing in all this is appropriate examination and direct. Appropriate examination, especially in children, proper pulse oximeter screening is very important. Okay, you look at the four limb saturation, look at the four limb pulses. Just absence of murmur doesn't mean that the child doesn't have a heart disease. Temporarily, we can directly project here video. Yeah. Now change. Yeah. So the second case was of a infracardiac TAPVC who was operated and the child did well. The next is another similar case. Child was born at term, apparently well, sent home after delivery. However, on 27th day of life, the child worsened and developed severe metabolic acidosis and again was referred. What would we think? Yeah, it could be a duct-dependent lesion or something else, right? You take an X-ray, the X-ray is black. There is very decreased pulmonary blood flow. Indirectly, this X-ray suggests that it is probably a significant decreased pulmonary blood flow, so most probably a duct-dependent pulmonary circulation lesion. So it turned out to be a pulmonary atresia, intact ventricular septum with a duct-dependent lesion. So the child, because he was very sick, pH of 6.9, he was stabilized. The duct had closed, but he was stabilized and a BT shunt was done. while we know that the lesson learned from this case is, while we know that the duct generally closes at second or third day of life, but the duct closure can be delayed as late as 27 days. So these are the duct dependent pulmonary, like pulmonary atresia, critical tetralogy, tricuspid atresia. Okay. Another case is a 3-day-old child who was just saturating 75%. He was diagnosed that the child has a heart disease. So what they thought in this case was whether it could be a persistent pulmonary arterial hypertension, because they gave oxygen and there was some improvement. Why? Again, they thought that there was no murmur detected. So the neonatologist thought, okay, it is PPHN and continued to treat. However, it turned out to be a transposition of great arteries. Okay. Why I am telling you all these cases is, if we don't diagnose this, or if you don't do appropriate bedside echocardiography in these children, we can lose these children. Okay, if you diagnose it as a duct dependent lesion, a diagnosis as a transposition, they have excellent outcomes in today's world. Okay. So what I would like to drive home in a neonate is, if there is no murmur, don't think that there is no congenital heart disease. Okay. So you can still have very critical congenital heart disease, like a critical coarctation, hypoplastic left heart syndrome, retransposition of great arteries, total anomalous pulmonary venous drainage. All this I have already given you as case examples. The last case, whenever there is tachycardia, okay, don't always think it might be sepsis. It could be a supraventricular tachycardia. SVT itself can cause what is called as a tachycardiomyopathy. Okay. So not all tachycardias in newborns are sepsis. You do a ECG, confirm it, and ensure that you treat it appropriately. Okay. There is a lot of difference between management of sepsis versus a SVT induced tachycardiomyopathy. To summarize, a neonate in shock, always check for all 4 limb pulses. Okay. You can diagnose a coarct. All 4 limb blood pressures if possible. It's not like we have to do physically. Now all the new NICUs have NIBP machines. Do this thing. 4 limb blood pressure checking. Check for the pre and post ductal saturation. Yeah, you might be having a duct dependent lesion, or it could be a PPHN. If possible, do a blood gas. Okay, look for lactate. If the lactate is elevated, then the perfusion is not good. If any suspicion is there, start prostaglandin. Always ask for a bedside echocardiogram. For all the pediatricians or all the physicians whom we get a child in shock, definitely try to get a bedside echocardiogram. A lot of us are doing this bedside cardiogram. Don't fall for this trap. Lots of the times, the baby cried immediately after birth, everything is fine. Baby doesn't mean that everything is might go well for all. Okay. No murmur heard, that doesn't mean that there is no heart disease. Don't fall for this. Don't think it's always sepsis. Something saturation improves slightly with oxygen, it can still be a heart disease. Don't rely too much on improved saturation, and don't think it's a lung cause. Sometimes, most of the times, they say fetal echo is normal. Okay, so they will not have a postnatal. No, most forms of critical congenital heart diseases might not be picked up in fetal echocardiogram. A message for all the gynecologists or treating pediatricians or the cardiologists. The first thing they ask, sir, my child's fetal echo was normal, or a TIFA scan was normal. Why does he have a heart disease? No, the pickup rate is not that great. So the truth is, every crying child can have a congenital heart disease. Think of it, every duct-dependent lesion can be silent. Okay, you need not have a murmur. Every shock neonate, you should always think as a cardiac cause, as a differential diagnosis. Okay, so as next, because we are running short of time and there were some glitches, I would give my next talk or the continuation to heart failure or whatever, the misses in pediatrics by Jyoti Prakash. Next, come.